So, hello and welcome to this week's episode of the Two Medics podcast. My name is Tharusha. I'm a cardiology registrar subspecialising in intervention, and today it's just me. Imran's. Well, what's going on with Imran? So there's a bit of explaining to do. That makes it sound really like ominous sounding and stuff. Basically, we've both been really, really busy. I think we can complain about how busy we are every week. So I'm sure like the people who listen will kind of like know all the reasons. Like I'm training for the London Marathon. I'm writing my MD thesis. Obviously, I've had quite a big bulk of on calls and stuff. And Imran does a lot of extra stuff, doesn't he? Extracurricular and curricular. And it's just finding the time. What with that, and then like also being unwell and stuff, it's just been really difficult. Although that sounds kind of doom and gloom, as with this next bit, which is that kind of talking to one another, we've decided that perhaps trying to put out episodes every week isn't very sustainable. It's difficult. We've been doing it for 2 years now, I guess, if we've done over 100 episodes. And we were kind of thinking if we could perhaps move it to either once every 2 weeks or probably more likely once a month. And that's not because we don't enjoy doing it or that it's not doing well. In fact, I've got to talk to you about a kind of new sponsor. But it's more that, just finding the time and to just kind of not make up stuff on the fly. We kind of decided that it's probably going to be a monthly thing. And that really kind of does coincide a bit with Ramadan that's coming up really soon. And so we kind of thought with that we'd probably dial back a little bit. I was still thinking that I'd perhaps do like a few solo episodes here and there just to kind of like, if I got time just to kind of put something out so that, if you really miss our voices or, want to hear a bit about what's been going on and you've been offline for a bit, then you can still do that. But the proper Two Medics episodes will be, probably about once every month, we think. We have been sponsored now by a company called Scrubs. I say company, but they're a group of medics like us, and they're mutuals from Twitter. So their kind of products are called Scrubs, SCRBS. So give them a follow. I think so. If you specifically the handle is at SCRBS_UK, and basically they make awesome scrubs. Now, I guess people are going to roll their eyes and be like, yeah, obviously you're going to say that. I've never really been the kind of person that's kind of thought I definitely want my own kind of personal scrubs. But honestly, that kind of rush in the morning, especially on a Monday morning, to go and get scrubs that fit me, and then if you're there 5 minutes late and literally all you've got left are either the very small or the extra large scrubs, and it's just ridiculous. So that's one advantage. And two, oh my gosh, the number of scrubs that I've worn that got holes in their pockets, or literally they've just got this this seems like a ridiculous thing to get excited about, but the standard scrub pocket positions. Now, I don't know about you guys, but the number of times where I've leaned over, this is embarrassing, but when you lean over and then your phone drops out of your pocket because of the placing of that, the number of times that's happened infuriatingly, when you're bending over a patient or whatever, it's just, it is annoying. It does annoy me. It does affect my choice of pocket. Anyway, the scrubs that we've tried, so they've got two colours at the moment. There's navy and burgundy, and they have just innumerable number of pockets. That seems to be what the nurses have kind of pointed out when I've been wearing them. One is that they like the colours, and two, oh wow, you've got quite a lot of pockets, and so I'm gonna say that. But also they're kind of really stretchy and comfortable. So it's kind of like wearing pajamas. So at the moment, these days, I tend to wear them when I'm doing nights, just because I think it fits in quite nicely with the night vibe, just to kind of be walking around in comfort. I haven't been wearing them much during the days, mainly because, going to the lab and stuff and worried about getting them dirty. And I think, when you get something new and they're still really quite kind of fresh and cool. I really like them. So anyway, we have a promo code. So if you do decide to check them out and buy them, if you put in well, actually, I think you can do. So if you do two medics, so TWOMEDICS 10, as in 10, then when you should get 10% off, which is awesome, right? So check them out anyway, and it really is like they are quite cool. So I do recommend them. I think they're quite a good gift. I might ask for some for my birthday or something. Anyway, yeah. So that's kind of exciting. It's weird that it kind of fits in with us kind of saying that we're going to do slightly less. But what we're hoping to do in kind of exchange for perhaps doing a fewer episodes is doing more on like YouTube and whatever. So unfortunately, that does mean you'll see more of our faces and stuff. And it just means we hope that like the content will be a bit better. So bear with me anyway as I go through the topics for the week. But I have to say, I mean, obviously today is kind of feels a bit auspicious. So I was supposed to be going on to nights tomorrow evening, but so this is the Sunday evening before the strikes start, and it feels funny. I feel like I'm pre-nights, but not in exactly the same way. There's usually a kind of nervous tension, whereas at the moment it's just kind of tension because I haven't really seen much in the news about the strikes recently. I mean, obviously I've seen a few tweets from Steve Barclay, who like standard like 9 o'clock on Friday evening was like, oh yeah, I've messaged the BMA to like talk about negotiations. Like, what, mate? You waited till you've had like months now. And two days before the strikes you decide on a Friday evening. I mean, that reminds me of like when I got like an email from HR at literally like 5 minutes to 5 about something that they said that I needed to respond to as soon as possible, you know, in order for me to get paid on time correctly that month. And when I replied literally within minutes, because I was like, oh my god, it's minutes before 5 and I was at work, I got the out of office reply even before 5. It's the same vibe, man. The same vibe. Like, they've just sent that out and being like, take that, I'm off. And, you know, it just shows like the massive disdain for junior doctors. And you can also, the thing that I've noticed with interest is how they've treated the kind of nursing strikes. Didn't they so they've offered to kind of go into negotiation with them, and then they've just completely blanked them, haven't they? They're just, you know, acting with a whole load of nonsense. And so it's looking, I think anyway, from looking online, like they're going to be more nursing strikes, and they basically just use this whole, you know, oh, we're going to negotiate as a way of just kind of delaying more strikes and just smoke screens and all that kind of stuff. And I think one of the important things that doesn't really get talked about when they do that kind of thing is how costly this whole process is to unions. And, you know, like balloting and stuff, you know, because it has to be done by mail, which I'm sure is something that is kind of purposefully done to suit the government to make it difficult for trade unions to do and also expensive, is that they want to make this as costly and as difficult for obviously the members, but the unions to do as possible to kind of orchestrate and organise. And there was a tweet recently from a trust that I think was also blocking emails between. Basically, people were kind of communicating amongst one another about how to organise themselves for the strike. So I think it was Leeds Hospital, and they blocked the trust doctors' reps from emailing doctors in the trust, which is apparently that's against. I think that's against certain like guidelines. It must be, right, but basically, just any means necessary. I mean, that's some shady stuff, and honestly, it just seems like there's like no level to which the government will kind of stoop, and you know, these people in power will stoop to kind of undermine people. And so, of course, predictably, like I was actually quite a junior registrar back in 2016. Shows how old I am. Still a registrar now. God, hopefully coming up towards the end. But anyway, I was a registrar back in 2016, and I remember like pictures of doctors on holiday started becoming like a focus of interest in the news. So like the newspapers were mining people's Facebook profiles and then taking pictures without people's consent, because, you know, like public forum or whatever. So I'm sure they're going to do that to us. And then putting out this thing, look how much doctors get paid, you know, just kind of stirring up indignation and stuff. But I feel like, I mean, if you're just looking around, it looks like unlike in 2016, they're saturated with the nonsense now. like in 2016, people were, perhaps like buy into it way more, obviously, because they voted, people have voted obviously for the Tories to come back into government, twice since then. But I think, you could see about how, the reaction to Gary Lineker and the amount of support for him across the divide, like even like Tories and stuff saying, oh, this is ridiculous. And just, I just don't think there's the same appetite for calling people out on the strikes that there was. But, I have no doubt that they'll still try to undermine the process and say that, doctors get paid in Ferraris and croissants and stuff. And so it's going to get dirty. And that is a bit scary. But what can you do? I mean, like, essentially, it is ridiculous. People need to get paid, in line. We need to get paid in line with inflation. There's been a real terms pay cut since 2008, and we're not worse doctors than the doctors that our colleagues were in 2008. We're not worse. We're doing more, and it's harder now. So we shouldn't be getting paid less than them, simply put. Anyway, so moving on to kind of like tweets from the week, I'm sure there are some kind of tweets in this thread, in this episode that will talk about the strikes, but just to kind of move on, because there are a few other really interesting topics. So there's a tweet from David Warreno, who's a fellow cardiologist. Hello, I think he's in Sheffield. I'm paying like particular attention these days to where cardiologists are, because so I am coming up towards the end of my training. The reason why it's so protracted is because I went out of training to do an MD. Oh God, how many times have I talked about that? I went out of training to do an MD, and then that was obviously prolonged because of COVID, because I did the okey dokey. I went out to do like research, then went back in because of COVID, then went back out again to finish my research, which was completely torpedoed by COVID. It's like, how can you recruit patients for a study when everyone, when like there's a pandemic? That looks kind of bad, like calling research patients up. So that's kind of like really prolonged things. But I'm coming up towards the end. So now, like, whenever I'm seeing people, I'm like, oh, where do they work? And I think the thing about that is something that people, and I'm not sure if people really talk about that, like when they're coming up towards the end of training, like, how do you get a job? Like at the end of it, how do you get a consultant job? It kind of, there's an air of mystique about it. And I think that's across a lot of specialties. I mean, like, there are certain specialties. I remember Steve Macon saying that, in Jerry's, in certain areas, like, as soon as the people get their ST3 number, people are thinking, oh, where is that person going to be a consultant? Trying to tap them up and stuff. And that's great. I'd have loved that. But obviously, I think in most specialties, and this is obviously one of the focuses of upset and disappointment and anger amongst junior doctors, is the number of applicants for posts that there are for specialty training posts, but also for consultant numbers, just not enough, and so it's so competitive. And so I just so what do you do? So the general advice that I've been given from other people is that you should approach people, because essentially there are places where if there's money and they like you, then people may well create a job for you, even if there isn't like necessarily a vacancy coming up. They could create a post for you, and to do that, you probably need to speak to kind of like whoever the head of the department is, and say, look, I really like working here. I'm thinking of buying a house here, or settling down here, that kind of thing, and just being upfront with whoever the kind of head of the department is. That's the kind of first way to go. But the other thing that you should be doing is probably speaking to the people senior to you, the more senior trainees, and just finding out the lay of the land, because there are a few things that you kind of want to know that you might not have picked up being on the ground as a junior doctor, like what the managerial side of it's like and what that kind of environment is, because there can be a lot of toxicity that you're kind of spared from and just not perhaps noticed, and you want to get the vibe on those kind of things. And I guess it's not like before, whereby, perhaps getting a consultant job was like dating, and, you needed to suss that person out before you make kind of like a really, really big commitment. I think, well, maybe it is like dating in that you don't necessarily have to be all that committed. And when you get a consultant job, it's not like in the past where you'd probably just stay there for life. People do still move from one consultant job to the other. So maybe it is a bit different to that. But it's in the same way, there's a lot of sussing out that's going on. One other bit of advice I got was that it doesn't matter what you've been like. Well, I mean, obviously it does matter from ST3 to ST5, ST6. that ST7 year is the year where people are really, really intensely watching you. So all that good work that you might have done those early years, you need to keep your nose clean in the last year, not upset anyone. And that's really difficult. And that's what made me think, I was thinking of when I read David Warrener's tweet, which said, really wish someone would write a book called Hospital Politics 101, How to Not Make Enemies and Influence People. I think it'd be a bestseller. And I know he's obviously being sarcastic, but the point, I think there's that whole thing that I know that we've talked about before, which is the unwritten curriculum. And I was like thinking when I was reading this, like what kind of nuggets of kind of wisdom could I impart to kind of, if I was to submit anything, any advice or any wisdom towards this book. And one of the things that I guess I've learned from being a junior doctor, and one of the things that I used to find so difficult, say as an F1, for example, was saying no and how to say no. Because saying no in a hospital setting can be viewed as aggressive, right? No matter how you say no. And so when I've written, I wrote a few things down. And one of the things I wrote was never say no. And I guess what I mean by that is being as creative as possible in kind of avoiding saying no to stuff. I remember when I was a junior doctor, and one of the things that used to really get my goat would be when you get called up about, I don't know, say you're reviewing a patient or whatever, and then the nurse or whoever's calling you be like, how long will you be? And I remember this used to vex me so much, because I'd be like, look, I could tell you half an hour, but say if in the next half an hour someone calls me about someone who's peri-arrest, right? Then that half an hour that I told you 15 minutes ago no longer is valid, I'm afraid, because I'm going to have to go and see that other patient. That might take up quite a lot of my time. But what's going to happen, and I know, unfortunately, is that you're going to call me in another 15 minutes time to say, you said you'd be here half an hour ago and you're not here. And then you're just going to waste more of my time asking me what I'm doing. And I'll be like, I'm actually really stressed right now because I'm with a sick patient or whatever. And I remember I used to go through these imaginary conversations in my head whenever someone's asking me, how long are you going to be? And I remember this colleague being like, I'd just say, I'll be there shortly. And I was like, oh, wow, that sounds like an answer. But it's not really an answer, is it? It kind of gives you the impression of urgency, but it's not really. And I think those kind of things, those kind of non-answers that kind of give something, but not... I mean, it sometimes works, sometimes doesn't work. These days now, I do try and level with people and say, look, I'll try and be there as quickly as I can. But these are the things that I need to do right now. And, I do find that in cardiology in particular, one of the problems, or one of the worst things about cardiology, I guess, is that sometimes regardless of what's going on, one of the reasons why it can be so difficult is, even though obviously cardiology is important, it seems to be next level important to other people that you see their patient right away. Because it stresses people out, right? If people are like, oh, stuff's going wrong with the heart, then the next logical step will be a cardiac arrest. Oh my God. And so you've got to be there right this second. Even if they've had left bundle branch block since 2016, you need to still go and run to their patient right there and then, because they're worried, right? And but the problem is that if literally every phone call you get is like that, then, you can't physically do it. But obviously to tell that story to everyone is very difficult. And I have to admit that I don't think I'm still that great at kind of managing it. I generally say, look, I'll come and see your patient. For a lot of people, that's enough. But the time frame thing, well, if you've got any better suggestions than saying shortly, which is what I still use to this day, 10 years down the line, then, I'd love to hear it from you guys. So the other things are finding allies, ultimately, the cohort of people that you're in, say, for example, if you're in a group of SHOs or your group of registrars, you need to have them on side. They're your backup. They're the people who you're going to be swapping your holidays with. They're going to be the people who cover for you if you're sick or whatever. And, it can be very difficult. I find that in the WhatsApp groups, some people are more engaged than others. Obviously people have their own lives and stuff, and they don't necessarily rely on you guys as a friendship group, and that that's sad, but that's just unfortunately the way it is. But kind of trying to form allies and kind of strong relationships with your colleagues. It sounds obvious, but it is important to kind of try and put the work in. And by that I mean, I try and be sociable. I try and try and get-togethers and whatever, like try and do stuff like that. Perhaps more importantly than that is to try and find mentors. So that's a bit of advice that I've been given, which is that, find someone senior, like find a consultant who, and say like, will you be my mentor? Like, and because, there probably is, there are people out there who could write the book and how to do it. And what the kind of people who've been in the department a long time, they will have seen it all. So it is worth trying to like tap into their knowledge and stuff. And so trying to get some mentorship is invaluable. And I don't think it's just from like getting advice from them, but it's like connections and that kind of thing, and just kind of hearing about opportunities early and stuff. It does require a lot of confidence though to like approach people, and a bit of brazenness that I don't necessarily think I have. I found it difficult. I've gotten better as I've gotten older at advocating for myself, and I think one of the reasons why I've done that is because I do think to myself, well, what is there to really lose by asking? The worst they could say is like make up some terrible excuse for why they're too busy or whatever, in which case you haven't really lost anything, and you've shown a bit of initiative, and that it's like a sign of respect that you want them to be your mentor. So those are probably my bits of advice for now. But obviously, as I have been a registrar for a long time, so maybe you should be doing the stuff that I'm not doing. So that you'll be more successful. Maybe that's it. Maybe just do like the opposite of what I'm doing, and then you'll be fine. Everyone will be fine. That's what Imran tells me anyway. Like when I get stressed about, I'm like, oh, don't know where I'm going to end up working. Don't know if I'll have a job at the end. He's like, mate, it'll work out. I felt exactly the same way. And I'm like, but how though? But how? And he's like, it'll be fine. It'll work out. Like, okay. So there you go. It will be fine, says Imran. That's his message. Okay, so there was a kind of thread on Junior Doctors UK subreddit, and I have to say straight off the bat, the mods on that subreddit clamped down that thread really, really fast. So they obviously recognised that some of the kind of vibe was going a particular way. But I wanted to read what the post was. And because the thing is that a lot of reactions to it were like, I don't see what the problem is. And I don't know. I mean, there's a whole load of dog whistles in there, but I wonder if I read it out, whether you can kind of pick up on it. So the post says, does the public want UK graduate doctors treating them? It's obvious the government does not care about UK grads. Interesting. Hence allowing the training situation an absolute shit show for UK grads where you are competing with the whole world. An excellent foreign grad colleague has told me that his sister and more than half of her class in Pakistan have already started preparing for the PLAB MSRA, MRCP from second year med school and hope to come here once qualified. He said this is normal in his med school abroad and presume it's the same in places like India, Nigeria, etc. That just means it's going to get even more competitive in the future as these students haven't even graduated, and with the influx of new students in the UK, the training situation will not improve, even if they substantially improve the training post numbers, as they do not have enough money. The only way we can sort this out is by using the public, in my opinion. The government just wants cheap labour, and the salaries in the UK are amazing compared to developing countries. Does anyone think that public cares about this enough to alter the government stance on foreign grads being on an equal ladder for training posts? Ladders, eh? They're obsessed with ladders. Or maybe we get UK med schools to change something, as surely there is no point in doing medicine in the UK only to have to do an F1 year, whereas doing it abroad and applying for an SHO role after doing a standalone F2 is an option. And this raises an interesting point, which I've kind of seen subsequently, which is basically a whole lot of people really resenting the fact that they have to do the foundation program. And I have to say, I think as a kind of separate kind of like offshoot, there were some other threads, and I don't think it necessarily was spawned from this, or maybe it was. You don't know really what's in a person's consciousness when they tweet stuff. But there was a thread that kind of was along the lines of people saying, what specialty did you believe you'd go into at the beginning of med school? And what did you end up going into? So Bethan, she's a great example. So for her, she thought she was going to be doing neurology. So she nearly quitted medicine completely in F1. And then she thought she did neurosurgery, and she did that up until quite a senior level. And then she left medicine to do disability assessment. And now she's in GP. So I mean, that's quite a kind of circuitous course, isn't it? And my point is that it can be really difficult to know what you're going to do. So when I was at when I started medical school, I think I pretty much thought I was going to be a surgeon. I didn't really know what that meant. Like, I like the idea of saving lives. I guess that's what like people talk about, isn't it, when they apply to med school, and the romance of that, and being like bent in from ER, and you know, that kind of thing. I should have realised that like I was much more like JD than Turk from Scrubs. Oh my gosh, that's probably too old a reference for people who might be listening. But anyway, through med school, I thought, actually, what kind of surgeon would I want to be? And then I quite like the idea of treating children. Oh, a paediatric surgeon. And so I think by the time I'd like finished med school, I kind of thought I wanted to do surgery. But then like, that's what I thought, you know, that's what I said. But now thinking back, like, what are the topics that I remember like not doing an awful lot of like surgical revision and not being like super into dissection. So who was I fooling, really? But really, it was during F1 and F2 that I kind of, you know, decided. So the first job was respiratory medicine, second one was HPB surgery. And when I was doing surgery then, you know, I went to theatre maybe once, very briefly. But I knew just from the cohort of surgeons that these were not people that I wanted to like work with. Like, I just didn't like the environment. I didn't like, you know, the ward rounds were like CRP, CT scan. And then you go to like the radiologist and hassle them for CTs. Like, it was just so mind-numbingly dull. And like when I'd like watch surgery at med school, you're just standing around for ages. And I just couldn't. And so I was like, oh my God. And I found that I was just identifying more with like medics, and then I did cardiology, and it was incredibly gratifying for me. Like, it was so gratifying, like, you know, seeing a person coming with a STEMI and go to the lab and they come out and they're better. Or like seeing someone like come in and they're like have a complete heart block and maybe need like a temporary wire because they're really sick, and they have a pacemaker and then they're better. Or like people who have like emergency pericardiocentesis and then they're better. You know, I was like, wow, all these things that you could do like straight away, and you make them better like straight away, and that suits like my really short attention span. But like, and that was through like an F2 job. And I just kind of like wonder if the value of that's perhaps kind of like lost if you're kind of thinking to yourself, oh, it's just like a way of getting like NHS experience. That was one of the kind of conversations I ended up having with someone on Twitter. Like, is that all you think it is? Like, NHS experience? Like, what does that even really mean? Like, what is the NHS experience? Like, operating in a healthcare system where like provision is like challenging? Like, isn't that like everywhere? Like, health inequality, isn't that everywhere? Like, what is the NHS experience? And I get the impression that really what they want is they feel like F1 and F2 is a waste of time, and or, you know, just like a way of kind of cutting your teeth or putting hairs in your chest, and they want that for the graduates from abroad as well, the international medical graduates. And I just kind of think, well, if they've got experience abroad, then, you know, they're going to have to go to induction anyway, and they're going to have to learn about how awful like NHS IT is through induction, like everyone else is, and it's different from one hospital to the other, and they've all got different elements of toxicity in their cultures, and their different kind of quirks and whatever, from region to region. Like, you know, the way that kind of like the health inequality in London is very different to the way it is in, you know, Yorkshire or Sheffield or, you know, east of England. Like, it's different all over. So when they say, oh, they need to get like NHS experience, what are they really saying? It's very difficult to kind of get them to actually pin down what it is, other than, oh yeah, we just think kind of FT is a bit of a waste of time, so we just kind of feel like they should. And, you know, there are people saying, well, you know, I had all this experience before, like, I don't see why I'd have to kind of do the I don't know, I didn't get it. But anyway, I guess like the kind of conclusion anyway that they have otherwise is that if you can kind of reduce, I mean, basically put off like IMGs, that's the other, I got the vibe from that whole thread that that's essentially what they want. They just don't want them, right? And then there'll be less competition for training numbers. And I do think that I guess it's a subtweet of that, or at least the kind of sentiment of those things is kind of why I kind of tweeted about I think it's like a Russian parable. I think there are kind of examples of it in many, many cultures. But the kind of most famous one is a Russian parable. I think it was of Ivan and Boris. And when I tweeted it, I didn't want to mention Ivan and Boris because I knew that someone would be like, oh, you're a communist, or some communist propaganda, whatever. But the way the parable goes is that Ivan is a poor man and Boris, his neighbour, has a goat. And Ivan is jealous of Boris's goat because, you know, the goat is by means of him getting milk and cheese and stuff. And he's, you know. So anyway, one day Ivan is fortunate enough to come across a fairy. He promises that he'll grant Ivan... I know it, the fairy's male in this Sunday. So the fairy promises to grant Ivan whatever he desires. And Ivan wishes that Boris's goat will drop dead. And basically the meaning of that parable, to me anyway, is that rather than kind of hoping for better conditions for all or whatever, or even just betterment for yourself, you'd rather just take away that opportunity for other people. And I do kind of wonder if there's a sentiment of like, if it's hard for me, then it's got to be hard for everyone else. Rather than, you know, thinking to yourself, if there were more training numbers, then, you know, this would benefit everyone. But I guess maybe that speaks to a certain level of insecurity. Like maybe they just don't feel good enough compared to the IMGs. And so they're worried that even if there were more training numbers, maybe they would get jobs over them because they're better in some way. Maybe that's what it is. I don't know. But anyway, that whole vibe was just kind of wrong. And there's, you know, I think the Junior Doctors UK subreddit is actually really good. There are some like really good posts and stuff. And a lot of the energy like towards the kind of to striking again, there was a lot of energy for that in the Junior Doctors UK thing. I think the way that they've kind of been really self-congratulatory about it since then has been rather like weird, because it's like, well, haven't got pay restoration, you know, haven't got the pay rise yet and stuff. And also like, you're never really honest about who composed you, and you were kind of unelected and whatever. So at the moment you're this kind of weird nefarious monolith that nobody really knows anything more about apart from the members within you, which, you know, is like the ERG and the Conservative Party. Like, who trusts that? And, you know, you can't help but wonder, like, when you don't feel kind of confident enough to give your identities out, like, why is that? That's kind of suspect, isn't it? Anyway, so that thread was trash, and it got trashed. So there you go. So more stuff about the strikes. So one thing that's obviously been, another thing that's awesome that the BMA have done is the rate card. Isn't that so cool? Like being able to say, look, this is the BMA recommended rate, and it's nice to have that unified rather than in the past having to be like, well, this trust offers this, and then having to send proof this way and that. And they did it for the consultants. And the interesting thing about that is that to cover the strikes, you know, consultants have been like, well, this is, you know, extra stuff. So to get extra pay, here's the BMA rate card. Love that energy. And so there was a tweet from Miran Pankania, and he said, a fundamental understanding of how the strike is designed to cause maximum destruction. You as the consultant should have the bollocks to say, this is out with my job plan. Pay me the BMA rates. Today's trainees are tomorrow's consultants, and your colleagues with a spine. So, you know, I think I like that. I like that vibe. It's good. Whatever rate they choose to be paid, ever so grateful that they're doing this for us. I do feel guilty. I got like a message from one of the bosses being like, oh my god, yeah, my note. So I messaged them being like, oh, you know, thank you so much for like covering my notes. And one reply being like, oh, you know, I'm kind of looking forward to it and whatever, you know, just like really like nice and whatever. And one of the guys is like, oh yeah, you know, it's terrible because I don't have like an SHO on the night, so it's just me. And I was like, mate, we've never had an SHO. That's what it is. Yeah. So yeah, and he's like, yeah, but I'll have to like prescribe night sedation and stuff. I won't have anyone to do that for me. And I'm like, yeah, that's exactly what we're doing. Yeah, that's what the Reggers are doing overnight. And, you know, that's the way it is. But it's really funny to see. And that's what motivated me to do that tweet about the discharge letters, because I'm like, I feel like it is going to be kind of eye-opening. Like, I'm sure it's going to be fine. Like, for the consultants, it's going to be fine. I think what will happen is that suddenly stuff will be very rational, and they'll be like, people will recognise suddenly the nonsense is nonsense, and there won't, and it'll be easier for them to say no and for the line to be drawn at their no. Whereas like a registrar's no is a no, but maybe, whereas the consultants are like, no, it's not no, but maybe, like no. So there'll be lots of that, and I think, in some ways, consultant reviews every day of like patients on the ward, that'll be good, but obviously at the same time, I don't think anyone's going to think, I'm not saying that this is going to be a bed of roses for anyone. Obviously, like a lot of stuff is going to be cancelled for this, and so it's not all kind of roses, but I think it will also be nice for some of our bosses to get like an insight into what, a partial insight, because obviously it'll be different for them, into like what we kind of like deal with, and just the kind of weird clunky into IT systems that we have to navigate for them quite often, and like a new score of 6 triggers an automatic like registrar review, and maybe they'll the ones that be like saying in the past, oh yeah, this thing happens, yeah, you need to get the register review, this thing happens, yeah, you need to get the register review, and then realizing that if all of those pathways lead to the reg, then that's just one person, and maybe increase some kind of empathy in that area, so I'm positive about it in that way. There was an interesting tweet from Ben Besker, who's talking to the medical students, because obviously there have been some like tweets about, oh, don't be a scab, don't cross the line, you're a scab, see, and stuff. And Ben had a kind of nuanced take, which is nice to see another cardiology registrar who's seems so sensible, such a sensible boy. I cannot emphasize enough how medical students should stay far, far away from hospitals on strike days, but not for the reason you think. Wait for it. Consultants are not cancelling clinics to create a great educational atmosphere for students. There will be no teaching. The risk of acting beyond competence is very high. And that's interesting, because there have been some emails going around, haven't there, where they've been asking medical students if they'd like to step up and be like clinical support workers or something, like some weird acronym, and paying them like £11 an hour to like, what, take up the risk? No, they don't do that. But yeah, so I thought it was an interesting take without calling anyone a scab. I think people have to do what they got, they've got to do. They're going to be people who are like worried about their visas. They're going to be like medical students who want to kind of go for their educational experience, or they want to, whatever. But ultimately, like, nobody can argue with the kind of massive mandate that there was for striking. And, I think people will do what they need to. I think people are kind of pretty united on this, which is amazing, especially because it's very difficult. I think it is quite difficult to unify doctors anyway. Like, we're all kind of contrarians and think we know better, right? Like, we hear a story, we're like, oh, but did you think about the PE? Did you think about that? Did you think about it? All love to be that person, I think. And so the fact that we've got so many people to agree to do this in the first place is amazing. And, so that's great. So, moving on. There was a tweet from Shivani Misra. You might have heard of her. She's a consultant in metabolic medicine and diabetes. And so she tweeted on the 3rd of March. She said, I'm a fellow of 2 Royal Colleges and will resign from one, bit dramatic, as their fees are £620. That's a bit dramatic. A ridiculous sum of money for virtually no benefits. I've been told that if I resign, I won't be able to use my post-nominals, sorry, God. I guess the rules are college dependent, but has anyone else done this? I mean, I can't, no, I don't. I've got enough letters in my own name without adding any more, but I think the whole paying money just to have a qualification thing seems kind of is off, isn't it? And she said, to clarify, I'm not planning on using the post-nominals if prohibited, but I wonder if there are grounds to use it within the year achieved specified. So if you say I got it this year, then you put that down, then it's like what I paid for that year kind of thing. And so someone said, Liam Barker, I put MR GGP 2013 and used the hundreds of pounds to go on holiday instead. Yeah, fair enough. I think that seems like a slam dunk, doesn't it? Like, what does the money actually pay for, really? Like, to keep the letters? Wouldn't do that. But there was like an interesting reply, which was like, an alternative view. Ask not what the college does for you, but what you can do for your college. Isn't that like some kind of war slogan? Isn't it? Ask not what you could do for your country, but what your country... No, ask not what your country does for you, what you could do for your country. Did Churchill say that? Or so, it was like some war slogan. But it's for the Royal Colleges. That seems weird. Anyway, so the person goes on to say, colleges provide powerful ways to participate in improving their profession. Committees, editorial boards, exams, tutoring, education, being an officer, I don't know what that's about, etc. And that was number one. I'm not sure about the other ones. But look, what, you're going to pay like £600 a year for the privilege of doing that? Like, if you have to pay to be able to influence, it just seems a bit weird, doesn't it? It's like a bit of a like pyramid scheme thing, isn't it? That's what it sounds a bit like then. I don't know. Anyway, Johnny Gukin was there to be the voice of reason. He says, Oh, sorry, I shouldn't say who that person was. Whilst I agree that college participation can be brilliant, speaking as a college trainee, trainees chair myself. All right, Johnny, chill out. I disagree with your alternative view. We are membership organisations. We exist to listen to, advocate and provide education to our members. We 100% agree on the need for more participation from members. But there is a huge anti-Royal College sentiment out there currently. We don't overcome this by asking more of our members. We need to demonstrate clearly and effectively what we bring to the table. Yeah, what do you guys do? I mean, that's literally the question, isn't it? Like, what is that money paying for other than the numbers at the end? What, like, you get like a newsletter or a journal every year? There is a cost of living crisis and a cost of training crisis. Royal colleges have to be part of the solution of the latter. I know loads of work being done by great people across the Royal Colleges, but there is something in innovating how we communicate this as organisations. I really worry about this perception that Royal Colleges outside of the HEGMC are part of a great big amorphous blob, that word, oh my gosh, who are out to bleed trainees dry from our wine cellars. It's got to the point where literal BMA committees are publicly threatening to sort the Royal Colleges. Anyway, that's interesting. I don't think, yeah, I mean, I've got MRCP. I'm never going to pay for that. What's the point? It's just, got enough letters in my name. Long enough. There was a thread from OrthoPodReg. So that's Simon Fleming. So he's he's done a TED Talk, quite kind of like prominent OrthoReg, who he espouses the virtues of kind of being good to each other, right? Anti-bullying. And he found an email that, I'll just read this to you, gosh. Are you a male medical student? ? Then we need you, finger pointing at you. Again, like a war. What is this with the people in the war slogans? No one talks about the male disadvantage, quote. A qualitative study exploring the lived experience of male medical students in Nottingham Medical School. Traditionally, medicine has been a male-dominated field, but in recent years, women have taken over as the majority in medical school populations. Dr. Blankety Blank would like to invite you to discuss your thoughts and experience of medical education here at Nottingham in light of this recent population shift. Because I guess, like before, female medical students were enrolled into medicine, there was probably a paucity of like experience dealing with men. Or is it the fact now that there are women there, how it changes their experience and how it might be a bit awkward sitting next to a girl or something? Or what is it that they're hoping to achieve from this? In his quote tweet of this, he said, when all you've ever known is privilege, equality feels like oppression. And that is kind of the vibe, isn't it? Like, no one talks about male disadvantage. Like, Jesus, really? Is that what's going on here? Like, I think one of the issues that people seem to have, or seem to say with kind of trying to push for diversity, is that they kind of imply that perhaps all the men have got there by merit, and therefore anyone else who's kind of entering that space must be there to kind of like fill a quota. And I think there's a kind of implication in that men must be the best for the job or something. Is that the implication? I mean, that's certainly the vibe I get. So I do think it's funny to suddenly now frame it as like male disadvantage. I think there are lots of issues and, horrible, horrible stuff that afflict men, like toxic masculinity, for God's sake, like we need more studies on that. I think because I think like the kind of patriarchy, it hurts everyone, doesn't it? It hurts men and women, and you know, there's that phrase I probably say too much, which is like the rising tide lifts all boats, or kind of, you know, that's a great phrase. And I think the thing is that if you improve diversity, you actually make the situation better for everyone. And I'm not going to pretend that like these don't have mental costs. Okay, fine. Like, you will go from having a room which might have been full of like people who all look like you to having it where kind of people don't all look like you. But that is the experience that it is for like a woman. Like, imagine how it is the other way around. And that kind of cognitive discomfort, I guess, perhaps of, you know, it's like when people kind of say, oh, you know, like I'm walking down the street and I hear lots of people speaking different languages. I'm like, really? How does that like hurt you? Like, what kind of fragile mind? Like, I don't know if it feels weird for a second to have someone having a conversation like across from you that you don't understand. But that's it, isn't it? That should be gay. That's like life and situations. Like, you don't have to be part of every single conversation. You don't have to be part of you don't have to be the in crowd all the time. Like, that level of discomfort is good. Like, because you might have to you might learn something kind of becoming part of a kind of wider, more kind of cohesive, greater group. Anyway, that was kind of an interesting one. So I'm probably not gonna bore you for much longer, but I did think that there was a tweet from Rohin where he was replying to a GP, well, not directly, as he said, not really sure the point of these threads by GPs bashing hospital doctors other than to score brownie points with their own tribe. Of course, hospital discharges can demand ludicrous things from GPs, and we know that, right? It's a tale as old as time, you know, like GP to check user needs tomorrow, or like GP to, and like some of the stuff they asked GPs to do is like bonkers. And I think one of the problems was like, when I was an F1, I guess, again, I did GP as an F2, and I'm ashamed to say that was where I got a lot of insight into like what would happen when, you know, the letter would then turn up in GP. Not so much from me seeing the letter myself, but from like, you know, just kind of like listening to like the GPs talking about it. And I do think it's funny, like, because obviously there's bashing either way and whatever, like people cuss whoever, and whether that's cool or whether that's not cool. And, you know, I'm kind of like in two kind of courts on this, because courts or camps, I don't know, a bit camp, I guess. Like, I guess like people come onto social media to like vent, right, and say like what's upset them. And we do have our silos. We have our, you know, we have kind of mutuals or whatever who will be like, oh yeah, that's terrible. Like, you know, regardless of like what you said, and perhaps sometimes even how reasonable it might be. And I guess as human beings, we kind of want that validation. And at the same time, obviously, we should like be nice and show solidarity with other people and see it the other way and whatever. And I think that's why it's good, like in this example that Rohin's given, that he's not kind of named the person directly. And even now, looking back at it, so this tweet was from a week ago. I'm not able to kind of clearly recall like who or what he's talking about. So I think that's probably the best way to do it. But then you got to kind of like complain about what's happened and what, you know, and maybe if that person who did it sees that and sees it in that kind of non-accusatory way, and they know that they've not directly been called out about it, so they're not going to get hassled online about it, then maybe they'll have a think about what they said and whether, you know, it was a reasonable thing to say or not. It's funny, right? But anyway, he goes on to say, yeah, as a basic inpatient ward round, we sent everyone home for GP to organise heart transplant and brain biopsy, pad out our own clinic so that they can have a 40-week wait so that we look busy on the golf course by 10 a.m. He goes, real world, hospital doctors and GPs get on just fine. Depend on another, seek advice from each other, value each other's specialist knowledge, and realise their main source of stress is not the other party. So I think the thing is that, I mean, we've all had, we've had like stuff that's kind of happened with colleagues that's just been suboptimal, suboptimal. But that doesn't necessarily mean that they're all terrible, right? But I think we should be able to talk about it without it seeming like we're cussing everyone. Is that the right answer? You know what? I've got to say, like, I'm kind of like figuring that stuff out. And so in these situations, I tend to kind of like wonder what someone smarter might think on the topic and then correct me and tell me what to think about it. So I still am not entirely sure on that one. But I think if it's kind of anonymized and whatever, not too specific, then I think like social media offers the perfect catharsis, and you don't need to be talking about every single colleague in that specialty. Even if there is probably a theme, we know that, you know, for every kind of like one or two experiences that you have in that way, there's going to be so many others who you're not kind of thinking about or talking about because they're not doing that, and so they're just not in your consciousness. But there you go. It's like on that drive to work, isn't it? And you come across two people driving like crazies, and obviously you've driven around, you know, in the kind of company of many, many other people, but it's those two crazies that you're kind of, you know, will probably most affect your kind of recollection of what that journey was like. Cool. So I think I've probably come up towards the end. Was this thing by Minna? No. Okay. Fine. Oh, there's one more by Rohan. Sorry. There's this tweet, which is just a 2-liner, but it does make me think. It goes in, just asking questions wouldn't be anywhere near as annoying if they were actually interested in answers. And even though he tweeted that, when did he tweet that? On the 8th of March, 4 whole days ago. Oh my God. It really made me think, because there is a whole, and I definitely do this to like troll people. I do it to be annoying. Sometimes I try and use my kind of annoyingness for good. And I find that there are people who will ask you questions like they're a kind of gotcha. You know, like the whole, what is a woman? That's the like, best one, isn't it? What is a woman? Like, oh, you've got me. I have to give you a definition that you'll then be like, biology, and all this kind of stuff. And it's funny because I find that if you were to kind of like flip that around and then start to ask them questions back, then that kind of discomfort. And I realise that often the way the reason they do that is obviously to create, I mean, it's obvious, isn't it? To create discomfort and to like, you know, have you like explaining yourself in this way where they're kind of like, oh, got the upper hand. Oh, yes, this is silly and whatever. And it's annoying, isn't it? It's annoying. I can't believe it's, you know, how long have I been on the internet? And that's the conclusion. But I thought it was profound when I read it at the time, but maybe it's not. Anyway, so the things that I want you to remember, just in conclusion, one is that yes, Imran and I are probably going to be going either down to like once every fortnight or probably once every month. And we're kind of wondering like when is the best time to like release an episode. And I was thinking it might be funny to do it like on payday or something, but you know, whatever. And so there's that. And 2, new sponsor. So please check out at SCRBS_UK and use the promo code, so TWOMEDICS10 promo code to get 10% off your comfort driven scrubs. And if you do that, please tweet us, and so then that'd be really awesome to see you in your new kit. That'd be really cool. So those 2 things, and anything else? No, that's it. Well, anyway, thank you for listening to me rabbit on for nearly an hour. Oh my God. This is going to go out unedited, so I'm really sorry about all the pauses and me like sipping on my tea and stuff. Got a bit of a sore throat. So for all of you guys striking out there tomorrow, best of luck. I hope you wrap up warm. I bought myself a thermos flask. That sounded a bit northern for a second there, didn't it? Especially. So, you know, see you out there. I can't wait to see your placards and stuff. Stay strong. And, you know, I hope we get the pay rise that we deserve. And yeah, so there should be an episode with me and Imran next week. So looking forward to speaking to you again then. Take care, everyone. Bye-bye.